Sreekanth Shetty. The myocardial revascularization is really a burning topic in a diabetic population. You know, the literature says we should try to use more of a surgical revascularization versus PCI procedures. But we are practicing more of PCI procedures than the surgical procedures. I think he will try to put a little bit more light on this.
At the end of 9 minutes, I will request you to stop. Thank you.
Can I have the slides, please?
Yeah, please.
First up, I thank Dr. Nagra Desai and Dr. Prabhakar Koregol for this opportunity. And I also, I'm worried that they have given me a very difficult topic to talk about.
My God, no.
As an interventional cardiologist, I'll try to be as fair and to the topic and also keep it as scientific as possible, because, you know, biases can creep in. We know how coronary artery disease in diabetes is challenging. It's also one of the major contributors for morbidity and mortality for diabetic patients. Anatomically, biochemically, the disease is far more complex than in non-diabetic individuals. Accelerated atherosclerosis, more tendency for thrombosis. They also have myocardial vulnerability. They have autonomic dysfunction, which makes them more prone for arrhythmias. So more frequent asymptomatic or silent disease even when they have very advanced disease, and they are more likely to have triple vessel disease, and the acute coronary event tends to be more severe, and they have more frequent comorbidities like renal dysfunction or atherosclerosis in other areas such as cerebrovascular disease, peripheral vascular disease, which also adds to the challenges when they have to go for revascularization such as PCI or even during CABG. And unfortunately, when drug management of CAD has evolved, it has not been specifically designed for diabetic patients. It is a broad set of pharmacotherapy that has been designed for diabetic as well as non-diabetic individuals. So there is nothing specific that has been designed for diabetic patients.
Hold the mic a little up.
Yeah. So when a patient has been diagnosed with coronary artery disease, now at what stage do you diagnose them with coronary artery disease? Dr. G.G. Shetty spoke about whether we need to screen or not screen for coronary artery disease in asymptomatic individuals. So how do you arrive there is the question, unless the patient has symptoms. If a patient has asymptomatic silent ischemia, you just have to stick to optimal medical therapy. If the patient has an area of large ischemia, as demonstrated by non-invasive testing such as myocardial perfusion imaging or a stress MRI or dobutamine stress echo, and if a patient is considered to be high risk, then you may assume that that patient is suitable for revascularization. And if the patient is not suitable for revascularization, you aim for optimal medical therapy. If the patient can be revascularized, then you choose whether you should do angioplasty or bypass. In symptomatic patients, stable CAD, again, if the patient has high risk features, you choose to triad them towards revascularization, otherwise you choose medical therapy. If a patient comes with an acute coronary event, NST, ACS or STEMI, then that's a different matter altogether. Now, when a patient has to be revascularized, what are the advantages of angioplasty? They are obvious: less invasive, quicker recovery, improved short-term outcomes, and suitable for high-risk surgical patient. But the problems are with restenosis and reocclusions, which are higher in diabetic individuals, and stent thrombosis and myocardial infarction in post-PCI patients is more common than in non-diabetic individuals. And also you have to factor in the possibilities of radiation exposure and contrast-induced nephropathy during complex procedures. And the benefits of bypass surgery are complete revascularization, better durability, like 10 to 15-year graft patency, and improved long-term survival. The risks are more short-term, that is surgical trauma and bleeding, graft failure and reocclusion over the longer term, which is higher in diabetic individuals as compared to non-diabetic individuals. And the neurocognitive decline and stroke, which can happen in the periprocedural period, which is also a concern when you compare it with angioplasty. If you look at the historical data, you can see that depending upon how long the follow-up was and how many patients were included, mortality benefit was shown in trials which had longer follow-up, but trials which had shorter follow-up did not show mortality difference. But there was a clear advantage of bypass surgery in terms of reduction of MACE, that is particularly repeat interventions were less in patients who underwent CABG. And even the more contemporary trials like the Freedom trial showed that CABG was better than angioplasty in patients with multivessel disease, and this despite usage of more contemporary techniques with angioplasty and the more recent stents. So which means that clearly bypass surgery has an advantage over angioplasty in patients and even mortality benefit in patients who have multivessel disease and diabetes. And in patients with chronic coronary syndromes, you can see over here, unfortunately I don't have a pointer, angioplasty with OMT is not better than OMT alone. CABG plus OMT also was not better than OMT in patients with chronic stable disease. As you can see over there, there is no statistical difference. But if a patient of multivessel disease with diabetes is undergoing revascularization, CABG with OMT was better than angioplasty with OMT. Even the most contemporary, this is 2023 meta-analysis of the most recent trials showed that the revascularization outcomes of patients with diabetes using CABG was associated with reduced long-term mortality, myocardial infarction, MACE, and repeat revascularization. And the contemporary data says there is no difference in long-term stroke as well because of better use of better techniques with bypass surgery. But this benefit was lost in women. And this is the chart of the same trial, and won't go into the details of that. So does that mean that for every patient of coronary artery disease with diabetes goes for bypass surgery, or are there specific situations we will choose one over the other? So in patients presenting with ST elevation MI, clearly there is no choice. You have to do angioplasty because even in the diabetic subsets of lysis versus PAMI, there is reduction in death or MI at 30 days, higher infarct-related artery patency, and improved LV function, and improved long-term survival in patients who undergo angioplasty in ST elevation MI. However, in patients who have diabetes with ST elevation MI, whichever way you treat, their outcomes are inferior to non-diabetic patients. And should a patient of diabetes with multivessel disease undergo a non-LAD primary PCI, later on they should have an evaluation to understand whether for the remaining disease plus LAD, whether bypass surgery is better than staged angioplasty. So that choice you can make using ischemia-guided therapy or non-invasive testing, or IFR, etc. For patients presenting with non-ST elevation MI, the choice is not as straightforward as in ST elevation MI. These patients can be considered like stable CAD in terms of revascularization. And based on the recent trials of the FAME2 trial, if the patient of NST elevation MI has had one culprit vessel treated, then for the rest of it you can choose to do FFR guided PCI. However, in patients who have NST ACS, not all patients are the same. Some of these patients are high risk or very high risk because they have hemodynamic instability, cardiogenic shock, refractory chest pain despite medical treatment, life-threatening arrhythmias, mechanical complications, and ST segment depression more than 1 millimeter in 6 leads, etc., suggestive of high risk pattern. In these patients, you cannot wait to do a bypass surgery even if they have multivessel disease. You will have to urgently revascularize by doing a angioplasty. When you do angioplasty in patients with diabetes, it has been shown that when you compare contemporary stents with older generation of stents, the benefits of contemporary stent technologies is lost in patients with diabetes. And if a diabetic patient is on insulin, this impact is even higher. So how to choose which revascularization strategy? Angioplasty is acceptable in a patient who has an indication for revascularization. If the patient has single vessel CAD, not involving the left anterior descending artery, if the patient is frail, if the patient has porcelain aorta, or if there are complications of previous thoracic radiotherapy, or if the patient has limited life expectancy or multiple comorbidities. CABG, if the patient has multivessel CAD or has a robust DAPT contraindications, previous PCI complications like recurrent restenosis, reduced left ventricular dysfunction, CKD, or need for combined surgery like valvular or aortic surgery, or the anatomy is not feasible for PCI. And if a patient has an angioplasty, the post-angioplasty outcomes are not as great in patients. The immediate outcomes are the same in diabetic versus non-diabetic, but the long-term outcomes are not equal. Similarly, for bypass surgery, the immediate outcomes are not affected by diabetes, but the long-term patency of graft is lesser in patients with diabetes. What if the patient has left main coronary artery disease? In patients with high syntax scores, you should advise bypass surgery. If the patient has low or intermediate syntax score, you can consider angioplasty, but downstream complex disease favors CABG. And if you look at this, in PCI versus CABG for left main coronary artery disease, diabetes did not seem to affect the outcomes of PCI versus CABG choice, but within each category, diabetes versus CABG did affect the outcomes. So,
Last slide,
I'm finishing.
Last slide.
Yeah. So, in management of patients with left main coronary artery disease, as you can see, high syntax score or multivessel CAD or the presence of diabetes suggests a preference for CABG. However, if the patient has ostial or midshaft disease, you can do CABG or PCI. Just 2 slides.
Yeah, 1 slide. Last slide.
In patient who has multivessel or complex disease, such as distal left main, heavily calcified lesions in tortuous vessels, CTOs or here there is a preference for bypass. In patients with previous bypass surgery coming with occluded grafts, angioplasty may be considered. In patients with LV dysfunction, again bypass surgery is considered to be better.